Assalamu alaikum. Good evening. I am Amber Khan, Chair of Imana's Education Committee. Firstly, a big thank you to our Imana team for organizing today's webinar. Tonight, we will have a very important webinar, especially during the summer months, and that is on the topic of skin cancer and sun protection for all different skin types. This webinar is going to be led by Dr. Noreen Galaria. Dr. Noreen Galaria is a board-certified dermatologist with a laser and cosmetic fellowship and has been practicing for over 20 years. After spending time as an academic dermatologist, she moved into private practice 13 years ago and opened 3 offices outside of the DC area. She's also the CEO and founder of Inner Glow Vitamins, a dermatologist and plastic surgeon developed brand of skin nutraceuticals. On behalf of Imana, we would like to thank you, Dr. Noreen Galaria, for your time and for sharing your expertise with the Imana community. And we are very excited for tonight's webinar. So I'm going to go ahead and pass the mic to you, and you can begin whenever you're ready. Jazakallah khair.
Thank you so much. Assalamu alaikum. I actually really appreciate the invitation. So thank you so much. So today I was going to talk a little bit about skin cancer and sun protection. Thank you for the introduction. So I am a board certified dermatologist, and we do a lot of skin cancer in our offices. So I would say it's probably the bulk of what we do. And what I've done is I've kind of, done a quick and dirty, the top 3 skin cancers and some of the tips and tricks. I figure hopefully most of the people listening are not dermatologists, and so it'll just be a nice refresher. I'll go ahead and get started. Okay, so we're going to be covering melanoma, non-melanoma skin cancers, sun protection methods, and then vitamin D and its role with regards to sun and supplementation. Okay, so why are we talking about this? July was Skin Cancer Awareness Month, and skin cancer is the #1 cancer in the United States. So we usually say 1 in 5 people in America are going to develop skin cancer by the age of 70. And across America, about 10,000 cases are being diagnosed every day. And a lot of these cases, not all of them, of course, but a lot of them are preventable because 90% of non-melanoma skin cancer is actually related to sun exposure, so UV exposure. Let's start with melanoma. So when we're talking about melanoma, of course, this is a cancer that's originating from our pigment cells, the melanocytes. And of all of the common skin cancers, this is the deadliest form of skin cancer. Over the years, there has been an increase in melanoma, and it's been pretty steep. So since the 1990s, there has been a 128% increase in the incidence, and that is the steepest increase of any common cancer. So I think that, we can all agree that we keep hearing breast cancer is on the rise and colon cancer is on the rise, and they are, but melanoma is on the rise even faster. And one of the reasons is because the world is actually just becoming progressively hotter. And we know that 2024 is slated to be the hottest year on record. Before that, 2023 was the hottest year ever recorded. And so the amount of UV radiation that we're getting and the amount of heat is just much higher. And so in addition to, kind of genetic changes, I do think that that is a big player. When we look at incident rates of melanoma, if you look, it was pretty stable from the 30s till about the 80s. And then there's kind of a logarithmic rise in the rates of melanoma. And a lot of people will say, well, this really coincides with when our ozone started to thin and when more UV started to really come into the environment. And so I do think that that, does play a role. The nice thing is, though, even though the rates of melanoma have gone up and the number of cases have gone up, the 5-year survival has also increased. So mortality has decreased. And so if we look in the 70s, a male with melanoma had about a 40% chance of 5-year survival. Now these are kind of old stats you can see, but in 2010, 2011, that 5-year survival has gone up to almost 90%. And so although there have been more cases, we do say, well, great, we're actually diagnosing more and we are saving more people. And I think part of that is earlier detection. We've gotten better, we have better tools. Part of it is better treatment. But I think that part of it is with melanoma being such a serious skin cancer. I do think there's been a little slide over the years where I do think that maybe we're overdiagnosing it. So if we're diagnosing it, a little earlier or overcalling it a little bit, I do think that those are probably cases that we then find are easier to cure. Okay, so when we look at skin cancer risk factors, the major factor is still being fair. So the classic, person who gets skin cancer is someone like this woman over here. So red hair, green eyes, freckles, and type 1 or type 2 skin is still the most common kind of, prototype or phenotype that we see. But in addition to that, I will say that with as the years have gone on, as I've been in practice longer, I am seeing a lot more skin cancer in darker skin types. So brown and black skin are getting way more skin cancer than they were like 25 years ago when I started. And so we know that other than being fair risk factors, the number one risk factor is probably sun exposure and tanning bed use, which is a type of sun exposure that is considered more intense, is a major player. Repeated sunburns, having a previous skin cancer is a risk. It makes you more likely to get future skin cancers. And then, of course, a family history of melanoma or having unusual moles or immunosuppression. Okay, let's talk a little bit about the types of melanoma. This is by far the most common type of melanoma that I see. It's called superficial spreading melanoma, and it kind of grows across before it goes deep or actually forms a nodule or a bump. When we look at this is classically somebody who's coming in and saying, "Hey, doc, I have a mole that I think is changing," or we do a regular skin check and we catch a mole like this. It often will have these kind of fuzzy, irregular borders, multiple colors. This blue-gray color in a mole is something that, kind of increases our stress level a little bit because it's definitely um, something that makes us think more of melanoma. The other thing that makes us think of melanoma here is the paleness in this mole. So we know that when the immune system is trying to fight a mole that is trying to turn into melanoma, it often does eat the pigment cells. And when that happens, we start to see these areas of pigment dropout in addition to pigment darkening. Okay, this is called acromelanoma. If for anyone who's listening to this webinar and is like my skin tone or darker, I would say take a second and look at your palms, look at your soles, and look at those of your family members. This is the most common type of melanoma that occurs in people with skin of color. And we're diagnosing a lot more of it. I always say to people who are darker, the most, you're not likely to get skin cancer, but if you're going to get a skin cancer, this is, a little high on the list. So I do see that patients are coming in with moles on their hands and feet that are changing. And because people don't think of skin cancer in darker skin types, these skin cancers, when we find them, are often deeper and more serious just because people were looking at them thinking, I don't know, maybe they're a wart or it just is a mole, but it's not going to change in me. I've got darker skin. And so I do really encourage people with skin of color to just at least be aware, do you have any moles on your hands and feet? Because that way, if they do change or they grow, you can kind of spot them a little earlier. Okay, another kind of melanoma is melanoma that occurs kind of around the nail bed here. Many people who have, skin of color will get these little stripes like we see here called melanonychia. That is pretty normal if you have a stripe here and a stripe there, but a darkening stripe and a stripe that goes onto the nail bed like this, so we're seeing it right around the cuticle here, that's a sign that this is not just a little stripe of pigment, but it is now something more serious and likely a melanoma. And so the sign is called Hutchinson's sign. And when we see it, I really do, in a patient like this, I would definitely move to biopsy. When we look at toes, though, it's sometimes hard to tell, is it pigment or is it just someone who stubbed their toe or got an injury? And so, let's see here. That's happening there. So we do know that hemorrhage or just a little hematoma under the nail can look very similar to melanoma and can look very scary. And if the patient has a clear history of an injury, that's great. But if they don't, many times in a patient like this, we know that it only takes a couple of months for the nail to grow from the nail bed to the top. So we'll often wait, a few weeks. And this is a patient who waited 2 months, but if you could start to see that there's a clearing at the bottom, it's not like there's a streak forming, but we actually see that the nail below is normal and clean, we can feel much more comfortable that this is actually a hematoma or, blood under the nail and not pigment. Okay, nodular melanoma. This is probably the scariest form of melanoma just because it grows fast. By the time a patient thinks about getting into their doctor, gets an appointment with their doctor, often this thing has already started to grow pretty deep. And I think one of the warning signs that I want to tell everybody about today is that this kind of melanoma, more and more, I am seeing it is amelanotic. So doesn't have pigment. And so many people will look at this and say, oh, it's just a hemangioma, no big deal. And a fast growing lesion like this, whether or not it's black, probably deserves a little bit of attention. Okay, let's see. Lentigo maligna melanoma is a common type in elderly people, often who've had a lot of sun exposure. They'll have these, sunspots, large, broad sunspots on their face, which can sit there for years and be totally normal. And then at some point, they start to get little papules or little bumps in them, nodules. And that is when I start to think, okay, this is now transforming into something more. I love the ABCDs of melanoma. I just think it's such a great tool for our patients. If, we talk about asymmetry, asymmetry can be either way, horizontal or vertical. So, an asymmetric mole, a mole that does not have a nice contained border, but has this kind of fuzzy map like border, we call it, a mole that has a couple of different colors, a mole that's bigger, so over 6 millimeters. And then, the E has been recently added, but a mole that's evolving. So if a mole is none of these things, but we look between two skin checks and we say, okay, this is a mole that definitely has grown. And I always say to adults, and it's different in kids, but I'll say, listen, you're not growing and your mole shouldn't be growing. So if I see a mole that's growing, that often is a reason to biopsy alone. Okay, so if we look here, this actually was a mole that was transforming into melanoma, and it was based simply on this little smudginess in the corner here. Um, it had always been two different colors, and they were pretty normal, but this was actually the issue here. And this one had this blue-gray discoloration, which with a little pigment here that tipped us off to this being melanoma. And then this one, I think, is a little scary for many dermatologists. This is a mole that if you just saw, you might not pay any attention to, but it was a patient that had been being followed. And so we knew that this mole used to actually be very dark and then looked like this. It had pigment dropout. And, when you start to see a mole where the pigment is being lost in an adult, then that's a sign that maybe the immune system is attacking the mole because it doesn't like it. And it can be a sign of melanoma. Okay, and here's another one, this little thing, not to give you, keep you up at night, but that little thing was the change that caused it to, convert into melanoma there. Okay. So what happens if you're doing a skin check? You've never seen the patient before. I would say that probably the most important thing that you want to look for, if you're like, yeah, I don't know, these moles all look a little different. Maybe the patient makes slightly smudgy looking mold. I would say look for the ugly duckling. So if you have a mole that just looks remarkably different than the rest, it could be, remarkably darker, remarkably bigger, remarkably lighter. But if it looks very different than the rest or just doesn't look like the rest of their moles, that's usually the mole that we're going to be the most concerned about. And then there are people who, have this condition called dysplastic nevus syndrome. These are people with hundreds and hundreds of atypical or precancerous moles. Obviously, their risk of melanoma is much higher than the general population. And this is the kind of patient that I would say, if you see, probably you want this person under the care of a dermatologist, just given the number of moles that they'll probably need removed and the fact that we want to put the dermatoscope onto each and every one of these moles just to give them a little bit of a better chance at preventing biopsies. Okay, so how do we actually recognize a benign lesion versus a melanoma? It's, I think once you see some pictures of subtle melanomas, it can be pretty scary. And there is, of course, nothing perfect, which is why we biopsy when we're unsure. But there are a few tips, and so I'm going to go through them. So benign nevi often have this little kind of corrugated or variegated appearance to them. So this one you might look at and think, oh gosh, it's got this little smudgy lightness, but this is a mole that if you ask the patient, they would say, yeah, this mole has always looked like this. It's always been a little bit, bumpy or pedunculated, and is a mole that really, when I look at it, I think, okay, this is a very benign looking mole. Also, moles that have a very consistent coloration. And I put this hand one here because I just told everyone to look at their hands. So if your mole looks like this, it's a very consistent color. You can see that it's very even within the fingerprint lines or the skin lines here. This is a mole that's very benign. And so that can just be followed. And then there are all of these benign lesions called seborrheic keratoses. So what happens with these is these are moles or these are lesions that patients will come in saying are, sometimes they call them barnacles, marks of maturity, liver spots, sunspots. And generally with these, if you see them, they tend to look a little bit warty and almost like you could like flick them off the top of the skin surface. Like if I look at this one here, this is something that could practically peel off the skin surface. If you're lucky enough to see these little, we call them horn cysts, these little kind of keratin plugs within the seborrheic keratosis, that should make you feel great because you can say, okay, this is actually not a mole. This is a keratosis and it's completely benign. Also, if it looks warty or cracked like some of these, that also gives us a lot of peace of mind. They come in many shapes and sizes. So as they are developing, patients will say, yeah, it started like this, and then it got a little thicker still. Maybe it got crusty like this one. And I would say that a lot of patients who come in really worried that they have a melanoma often actually have a seborrheic keratosis. Like their melanoma might be sitting somewhere else on their body. And I find it during a routine exam, but usually what's bringing people in is the seborrheic keratoses because what happens is we've taught everybody, hey, look for the ABCDs. And boy, do these ever follow the ABCDs. So they look like they're changing in every, way, shape, and form. And so I don't blame patients one bit for coming in for these. I think as a provider or a physician, when we're taking a look at these, one of the clues that are really helpful is just number. So usually when you look at someone with seborrheic keratoses, they'll have multiple different ones at different stages of evolution. So some are really thin, some are becoming thicker and warty. They often are itchy, which, classically melanoma doesn't itch. And when we look at them, they are aside from there being many of them at different stages, they are lesions that the patient will say, yeah, these have really appeared very slowly. Melanomas tend to be kind of a more solitary lesion, unless it's metastasized. I would say 100% of the time, it's going to be a solitary lesion. So if you see a whole bunch that look scary, and they don't have dysplastic nevus syndrome, I think we can be pretty confident that they probably are seborrheic keratoses. Okay, so just a second, talk about dermoscopy. I really think this has changed the face of dermatology practice. When I first started and we were just learning to train on these, we were doing a lot more biopsies. And I think we've cut our biopsy number by half because we've gotten really good. So initially, I think the dermatoscope was a very early rudimentary tool. We didn't really have a lot of ways to tell what was benign, what was malignant. But as the art of dermoscopy has increased, I think it's really become an amazing way to prevent biopsies in patients. Okay, so who should be getting a full skin check? I would say really anybody who has a lot of moles, so dysplastic nevus syndrome, or just a bunch of moles that are all different shapes and sizes. Anybody who has a family history or personal history of skin cancer, we should probably be looking at, we being the regular doctors, the dermatologists, and then people who have cancer syndromes or immunosuppression. Of course, if they already have evidence of sun damage, like actinic keratoses, then I do think it's really worthwhile to be seeing those people on a twice yearly basis, because as we'll talk about next, it's great to get things at the precancer stage because you really can prevent, an excision or a full-blown cancer in those patients. Okay, so when we look at melanoma, what are we looking at? We're basically looking at the thickness, and we call it the Breslow depth. On a biopsy specimen, we're looking at if it's ulcerated, and we're looking at lymph nodes. Are the lymph nodes involved? Okay, and as far as treatment, so if we're looking at treatment, generally, if we suspect a melanoma, the excision is really wide. So 5 millimeter to 1 centimeter margins on each side of the melanoma is what we're taking. So these do end up being still very large excisions. And when we're talking about melanoma, we are not talking about thick lesions at all. So, unlike a breast cancer where patients will say to us, well, my breast cancer is, X, multiple millimeters or centimeters. With melanoma, we're talking about 1 millimeter. So if it's 1 millimeter, the prognosis is much better. Once we get deeper than 1 millimeter into the skin, we are looking at doing sentinel node biopsies, and a little deeper than that, or a positive biopsy, then kind of puts them into the next stage where we're doing scans on them as well. Okay, so sentinel node biopsies, like I was saying, usually over 1 millimeter in depth is when we do a sentinel node biopsy. They are actually really helpful. For a while, we thought about getting away from them just because there's a very slight risk of lymphedema. And, 80% of people who we biopsy actually will have a negative sentinel node. And so, we really were trying to figure out, was it worth it? But if a patient has a positive sentinel node biopsy, they have a 50% chance of 5-year survival. Whereas with a negative sentinel lymph node biopsy, it's over 95% 5-year survival. So I do think even just sometimes for peace of mind or to dictate further treatment and studies, I do think the sentinel lymph node biopsy is really important and relevant. Okay. Melanoma survival rates are still great when we catch it early. And I will say the majority of people who come in for skin checks, which is why I love, you know, have people having their skin looked at by their regular physician or their dermatologist. I will say that these people usually have amazing cure rates. When we find them deeper, of course, the cure rates are still not great, and 5-year survival can be as low as 15 or 20% for stage 4. Okay, what about non-melanoma skin cancers? So the most common skin cancer by far is a basal cell skin cancer. And basal cells, classically, patients will come in and they'll say, oh, I thought this was just a pimple. And I figured it was a cyst because I couldn't get rid of it. But usually these are occurring in sun exposed areas. And if we look, they have a couple of really classic features. So they've got this pearliness that we'll often see. And because they're requiring more blood to feed the growth of the cancer, we do see these little arborizing blood vessels that are much brighter on the basal cell than they are on the surrounding skin. So we can see these little blood vessels elsewhere on the skin, but you can see they're much more pronounced on the basal cell. Same with this one here. And here's a really good close-up example. So, you can see there's blood vessels on this person's nose, but these blood vessels are running right through the bump. If this was a mole, which, sometimes patients get confused about, or if it was acne, it would not have these blood vessels running through it, nor would it have this really pearly appearance. In skin of color, we're seeing more and more basal cells. I used to see maybe one a year. I would call my residents in if I saw it. I would say I am seeing dozens in a year now, and they're occurring on skin of color. They tend to be pigmented just because we have more pigment in our basal layer. And so somebody who has a lesion like this, do keep a pigmented basal cell in mind if they're skin of color. Okay, so basal cell cancers are coming from the basal layer of the skin over here. And then the stratum corneum is where SCCs or squamous cell carcinomas and actinic keratoses are coming from. And both of these are incredibly sensitive to UV radiation. So if I can spend a moment talking about pre-squamous cell or precancers, actinic keratoses are something that we see a lot in people with type 1 and type 2 skin. They generally start as kind of these rough, scaly plaques with a little bit of scale. I always say you can feel them better than you can see them. So they feel a little bit like sandpaper. And people often have multiple precancers in one, sun exposed area. When I see precancers like this, I can almost guarantee that if we don't treat them, not all of them will turn into a squamous cell, but this person is going to likely get squamous cell cancers because there are enough here that even if the immune system can fight a handful of them, it's not going to be able to get all of them. And, if we neglect a precancer, some of them may clear on their own, but then some of them will get this thicker, kind of tighter appearance to them. Some will become a nodule. Some will actually develop this little, almost like a horn of scale. And if a patient is immunosuppressed or has a cancer syndrome, this is a patient actually who was a transplant patient, then they can really have many, many squamous cells and they can grow very fast and quite large. And so, in someone like this, I really do think, precancer treatment is really important. If left to its own devices, eventually they can ulcerate, they can scab, they can develop these, thick horns of scale because they are coming from the stratum corneum. And that is, when we start to worry a lot more about it. And basal cells, we always say, will almost never metastasize, but squamous cells can. And so a lesion that's been left on the skin too long does also have that additional risk that we don't worry about as much with basal cell. I just want to point out the lip is a high risk site, especially in someone who's a smoker or someone who is a tobacco chewer, a bond chewer. They are all people who are more likely to get squamous cells, and a squamous cell on the lip should be treated a lot more aggressively and more quickly than maybe a squamous cell somewhere else, like on the back. Similarly, people who have had radiation, and in the olden days, we still are seeing a handful of older patients who actually got radiation for acne back in the day, not knowing that it would cause cancer. And a lot of those patients also will develop squamous cell cancers. Okay, so how are we preventing squamous cells? Let's just go through for a second here. So the first thing is if we see precancers, we should treat them. So if I see a patient like this, I will talk to them about cryotherapy or topical chemotherapy with 5-FU, Efudex, or, we also sometimes use diclofenac gel if patients can't tolerate chemo creams. I do think that decreasing the burden of precancers is really important. And when we're talking about what do we choose, like, are we choosing to treat precancers with cryotherapy or are we choosing chemotherapy? I like to describe to patients that freezing or cryotherapy is kind of like me going into a garden and picking out a dandelion, like each dandelion root by root. So if I see a precancer, I freeze it and I get rid of that one specific precancer. If I'm doing chemo cream, that's kind of like spraying Roundup on the field. So what will happen is that I will get the precancers that I'm seeing and also the ones in evolution, which is great, but a little bit hard to do. And I'm just going to flip ahead here to this picture. So this is a person had precancers on their face. We started Efudex. Within a week, they look like this. Efudex, the chemo cream found a lot of precancerous damage on this man. And so week 3, he was looking like this. By week 5, he was starting to heal a little bit. And by the time he was done his treatment in 6 weeks, about week 7, he was starting to look very normal and very, and the burden of precancers had been lessened a lot. What keeps patients from doing this is this middle period, right? They look horrible, they feel horrible, they can get malaise, they don't feel like they can go out in public. But for the right patient, if you have a lot of precancers and you do this, you can dramatically decrease your risk of developing squamous cell. Another type of precancer, I'm just going to go back to this picture, is Bowen's disease. Bowen's disease, we often see in patients, and it's considered squamous cell in situ. We can see it on the skin. We also often see it on the genitals. So penile Bowen's is probably one of the more common areas we see it on, and sometimes the breast. Okay, let's see. And then I'm just going to, take a moment. Hopefully nobody here is doing tanning beds, but I will say the 20-year-old subset still does them. They are not safer than the sun. So if your patient asks you, I'm going to Florida, I'm going to the Caribbean, can I get a base tan in a tanning bed? That is actually much worse than just going to the Caribbean and getting your sun exposure. So we know that it increases the risk of developing squamous cells by 58%. And the risk of melanoma by 47%. I mean, those are huge numbers. Worse than smoking by some accounts. And so we do have warnings now on tanning beds. So the FDA now requires a warning label. And I watch, the teenage girls kind of walk right by the warning label and walk into the tanning bed. But it does say that use of indoor tanning does dramatically increase your risk of getting skin cancer, of photoaging, because we know that the sun is responsible for 80% of our skin's aging. And it's also increasing the risk of, obviously, kind of breakdown of your collagen, your elastin, and your precancer risk. Okay, so prevention, what do we do? Sunscreen is still our first line of defense. I always say when I'm talking about sunscreen, choose a broad spectrum sunscreen. And the reason is we have, two major types of UV rays. There's UVB, which is what causes tanning and burning. And then there's UVA, which is what causes cancer and wrinkles. So a broad spectrum sunscreen is one that is protecting you from both UVA and UVB. And that is something that is pretty easy to find. I think every patient should be using that. And we nowadays say choose a sunscreen that is SPF 30 plus. So 50, 100, they're not a whole lot better than 30. They're better, but not by a lot. And 30s often usually rub in a lot better. And so I feel like it's an easier sell for our patients. And of course, if you're going to be swimming, then water resistant, it becomes important. Okay. Mineral or chemical is always a question that I get asked. I'm a fan of mineral. If I'm going to ask my patient to use sunscreen every single day on their face for the rest of their life, I feel like a mineral is much safer. But I will say that chemical sunscreens do rub in better. And so, at the end of the day, use a sunscreen that you will actually wear. And then as far as safety goes, for chemical sunscreens, there is a sunscreen family called oxybenzones, and they are known to be endocrine disruptors and have a high incidence of causing contact allergies. So I do tell patients to try to stay away from those. They're also the ones that destroy the reefs, and so they're restricted in Hawaii. Okay. And then just checking the time here. I have a couple more minutes. Nowadays we talk about sunscreen alone is no longer enough. UV rays are strong. The climate change has made these the hottest years on record. And so if someone is going to the beach or is going to be out, maybe they're an outdoor worker, they're spending their summer outdoors, I do say, listen, try to put a hat on, try to get some UPF clothing. UPF clothing is clothing that protects you from the sun. Wear sunglasses. And then, the other thing that I often recommend, and many dermatologists, about 80% of dermatologists now across America recommend polypodium supplements. And I'm going to spend a few minutes on these because, this is actually where a lot of my research has been based. And so, just humor me. It's one of my favorite topics is polypodium. And so what is polypodium? So polypodium is a fern and it grows, it's native to South America. For years, tribes in South America have taken the leaves of this fern and boiled them into a tea to drink them when they know they're going to be in the sun. So tribes for hundreds and hundreds of years have been using this as an internal sunscreen. And it's been so, about maybe 50 years ago, we started studying it and we realized that it's an incredibly safe fern. No known side effects. We use it in children over the age of 2 for other skin conditions, and it protects us really amazingly well from the sun. So the sun does three things that we are trying to not let it do to us. It creates sunburn in us, it creates aging. So like I said before, 90% of our aging is from the sun, and it can create cancer. So the amazing thing about this fern is it has properties that actually improve all three of these negative things that the sun does. So, you know, I would say maybe like 15 or 20 years ago, people started putting these into tablets and giving them to patients who were high risk for skin cancer. They have kind of gone far beyond that because of their safety. And now people will take them, like I will take them just for anti-aging. I know my risk of skin cancer is not as high, but patients with melasma or with a risk of skin cancer, patients who just are trying to slow down their aging, will take polypodium, and it's been proven to work. The company that I own is called Interglow, and we are currently the only makers of polypodium in a gummy. It's something I'm really proud of. And so I'm sharing it here for you in case any of your patients are high risk for skin cancer. We do have it in tablet form, but it's no surprise to anybody that the gummy form has been much more popular. Okay, and I'm just going to show you a study that recently came out from an independent lab. So this is a patient, we sunburn one of their arms. So we sunburn their forearm, and then we give them 2 gummies, and we wait 1 hour, we sunburn their other arm. And this is the difference in their sunburn 1 hour after using 2 gummies. So 2 gummies taken once, that's the difference in their sunburn. So people with sun allergies, with melasma, patients like that are really benefiting. This gummy has polypodium in it, which is the fern. It has a little niacinamide, which decreases the redness a lot quicker, and passion fruit, which will decrease skin inflammation, which of course is something that helps to prevent our collagen breakdown. Okay, when it comes to UPF clothing, UPF clothing just talks about how tightly woven is the fabric. So a UPF of 50 is something that allows only 1/50th of the rays to penetrate fabric. So a regular t-shirt might only give you a UPF of like 4. A wet t-shirt might give you a UPF of 2. And so having these UPF shirts in people who are very prone to skin cancer has actually been remarkably helpful. And I do think it's decreased a lot of, precancerous damage in a lot of my patients. If a patient has a uniform, let's say, and they have to wear it outside every day, maybe they're, working outside for transportation or something, and they don't have UPF clothing, there is a very simple trick, cheap trick to fix this. So there's a thing called Sun Guard that you can buy. It's like those old tie-dye boxes. You basically throw the clothes in that you wish had sun protection in them, along with this laundry aid. And washing your clothes with this once will actually build up the sun protection in your clothes. So you get an SPF or a UPF of 30 to 50. I think it's usually closer to 30, and it'll last for 20 washes. And so for anyone who is outdoors and really has to wear something that doesn't have UPF, it's a great tip for your patients. Okay, and then vitamin D. So we know vitamin D is important, and I just talked all about blocking sun by using sunscreen. I know that there's evidence for immune benefits, anti-tumor benefits. And I know there's some recent evidence saying maybe we don't actually need to supplement as much as we previously thought, but the bottom line is 36% of adults are still deficient in vitamin D. So, what am I saying to those patients? I usually say to those patients, if you have skin cancer, well, maybe you shouldn't be getting your vitamin D from the sun. So if you are someone who does not have skin cancer, if you are someone like me, my risk is low, can I go out and get my vitamin D from the sun? Yes. I don't think I need to get it on my face. I can get it on other parts of my body, but I do think vitamin D from the sun is great if you are low risk for skin cancer. So we know that 13 minutes of sun exposure a couple of times a week is enough to maintain normal vitamin D levels. But if you're someone who I'm saying, listen, the risks of the sun outweigh the benefits, then I usually recommend supplementation if I'm not recommending UVB light, or I recommend getting it in your diet. Nowadays, milk and cereals are almost all fortified with vitamin D, so it does make it a little bit easier. Okay, and that is actually it. Thank you for letting me do this.
Thank you so much, Dr. Noreen. That was very informative. If anyone has any questions, please feel free to write them down in the chat. Also for Facebook Live, you can include your questions there. A couple questions actually did come to mind, just from your professional experience when it comes to our expertise, when it comes to skin cancer prevention. Do you recommend are there any brands you'd recommend for broad spectrum mineral sunscreens?
Yeah, I do recommend several brands. So I always, I hesitate to, kind of, put my name behind a brand, but I do think that there are certain brands that are really good, especially if we're talking about face sunscreen. Blue Lizard is something that I've loved for a long time. It's an Australian made sunscreen, and I use it a lot on my kids. Neutrogena, I don't like their Heliocare products at all, but they have recently come out with a lot of mineral sunscreens. So they have some nice kind of sheer mineral and tinted sunscreens that don't give you that white cast. I think those are great. And then there's some brands that I think do a really good job that are easy to find. Bare Republic is a brand that is at Target. It's pretty easy to find. Sunbum's mineral line is easy to find. And then there's a couple of like physician brands like Elta MD or Color Science, which also have great products.
That's great. Thank you. And when it comes to particularly with people of color, and you talked a little bit about how you can find, um, skin cancer on the hands and the feet.
Mhm.
Where do you actually recommend applying the sunscreen? Most of the time, people apply it and focus just on the face and the neck. For the male, sometimes they'll focus on the ears, but kind of disregard and neglect the other areas. So, is that perhaps a reason for why we're seeing it on the hands and feet, or is that just an unknown cause?
It's a great question. So I would say that the places that you should be applying sunscreen, kind of the general mantra is if it's not covered by clothing, it should probably be covered with a little layer of sunscreen if you're out in the sun. Um, the palms and soles, though, are a unique category. So, classically, soles do not see a lot of sun because they're down, right? And, and palms as well. But it's just a unique area where if there are pigment cells, I would say think of it as pigment cells kind of don't belong there. And so when they do show up there, they're kind of higher risk.
Gotcha. You mentioned the risks of skin cancer with tanning beds, which is something that research has shown for a long time. What about laser hair treatment? This is something that's quite common, particularly in those with darker skin tones. And does that pose a risk to skin cancer?
Yeah, fortunately, not at all. So, the ultraviolet radiation is what is increasing our risk of skin cancer, and the wavelengths of light that we're using for lasers are removed from that. So, they are wavelengths that are safe and don't increase your risk of cancer.
Okay, great. I have a couple questions about skin checks. For someone who maybe has no risks, no family history, when do you recommend that they start getting skin checks? And do you advise that they go to their PCP or primary care physician to do the skin checks, or do you recommend that patients see a dermatologist for skin checks?
I actually think that the primary care doctors do a great job with skin checks. And so often the people who end up at us are people who have a known family history, are highly anxious about their moles, or maybe have moles that, their primary care physicians have referred on to us to look at. And so in somebody with a higher, maybe family history risk, I usually say, because people are always asking about their kids, I say, listen, bring the kids in around the age of 8 because birthmarks or kind of uh, congenital moles can develop until the age of 8. Let's do one skin check at 8. If that skin check is fine, I'm usually going to see them after puberty. But the only people coming in to me kind of on a yearly basis for skin checks are people who have kind of a known personal or family history usually.
Gotcha. We have a couple questions here. Someone asks, do you recommend eating the gummies a certain amount of time before sun exposure?
I do. I recommend 1 hour because it takes 1 hour for it to fully, be functional is what we found through our research. And you can take them again. So much like applying sunscreen. So if you know you're like gonna be at the beach all day, then top off your sun protection. So when you reapply your sunscreen in 4 or 5 hours, you can take the gummies. They're harmless because it's a fern. So my 3-year-old niece by mistake ate like half the bottle one day when we were going to the pool, and it's fine. I mean, it's just a fern. And so luckily there's no known side effects to it.
Gotcha. Another question that we have is some of us are older and have already had a lot of sun exposure. What can we do now to prevent cancer?
Okay, so I would say that skin checks are kind of the number one thing you can do to prevent cancer. And then if you're worried about your face or your arms, places where it is easy to, kind of undo some damage, things that are generally considered cosmetic treatments actually do renew and rejuvenate the skin. And so I will say that they decrease your risk for cancer. So you're never going to get them covered, but retin-A at an older age, I think that is something that, you know, um, really don't think anyone who, is able to tolerate retin-A shouldn't be using it maybe after the age of 40 or so, because it is known to help prevent photoaging. It's known to help prevent precancers, and you look younger because of it. But if you have more damage than what you think retin-A can fix, or you've already, been using it for a while, then I think, peels and lasers and things like that can remove layers of damage. That maybe couldn't remove otherwise if you're just talking about photo aging. If you actually have bad moles that you are worried are going to turn into skin cancer, that's a bit of a different story. We're not going to remove those with cosmetic things like retin-A and peels. At that point, I think skin checks and things like sunscreen and these polypodium supplements become pretty important.
Great. Thank you so much. I appreciate that. I don't think we have any more questions, but thank you so much, Dr. Noreen, for sharing your expertise. We would love to have you back. I think it'd be wonderful to hear more information about the vitamins, the inner glow vitamins. So we'll be in contact with you. And for our audience that's listening, if you have any further questions, you can reach out to Imana Education and we can reach out to Dr. Noreen. If there's any other topics that you'd like Dr. Noreen to cover in the future, please let us know. Um, and we will have this recording available coming out soon on the Imana Education website and YouTube channel. So please check that out. And we have, inshallah, more webinars coming out this year. So please let us know if there's any topic that you would be interested in. On behalf of the Imana Education Committee, we'd like to thank again Dr. Noreen Galaria for sharing her expertise and her time. This was extremely informative and very easy to understand. So this is a great resource for medical students, residents, physicians, and the general community to refer back to once we have that recording available. Thank you all very much, and I hope you all have a great evening. Assalamu alaikum wa rahmatullah.